Okay, so I'm going to do my next presentation. Again, same map, same people. What I didn't tell you about our high school is that we're a private school. We have 150 students. We're located in Thunder Bay, just where that squiggly little line is at the where I live. So Thunder Bay is the students come from all those northern communities. We get them from 19 communities. Every year we get 150 students. We did a study on how many students have ever been to an urban environment before. 50% of our kids, 75 kids, never been to a city, had never crossed on a red light, had never been on a bus. So when you talk cultural shock, these kids experience that. They see it in videos, they see it in social media, but they never experience urban environment. So the adolescents were coming from those communities. We had 63% of our high school population, 43% of our high school population admit to an opiate addiction in 2010. So that's 63 of our student body. When we went to look for a solution, we could only find methadone. So we had to look at a different approach. So we had some principles that really guided us when we did our high school-based program. When you look at Ontario First Nations, again, 50% of our communities report prescription drug abuse. It's not heroin. It's all started with OxyContin, morphine, Tylenol 1s, 2s, 3s, hydromorphone. Our kids were sort of, well, when you think about our kids, they were growing up in homes. You think about crowded housing, we have lots of crowded housing. And so they were witnessing lots of drug use right in their home, right in their home. I had one kid, the 15-year-old I was telling you about, Suboxone is indicated for anybody under the age of 18 or 18 and older. As a treatment team, we had to decide, what are we going to do with this kid who's putting needles in his arms? Because he's not going to live until he's 18. So we treated him. We gave him Suboxone. He's still in treatment. He's 21 right now. And he's doing well. He's still alive. When you look at, again, the intergenerational trauma, our young peoples have had to deal with all the things that have happened in their community. We've also had experienced a lot of the drug overdoses up until, I think starting around 2005, they started to become more frequent. And 2 to 5 times higher overdoses in First Nations. So we had our leadership again. For Chiefs of Ontario was 133 First Nations. We're one of the largest provinces in Canada. We have 13 million people. And so 133 First Nations sounds like a lot, and it is a lot, because our geography is what separates us from the south to the north. As you go further north, it's like here things get more expensive, including the drugs. What we were seeing was lots of suicide, crime, child welfare, hepatitis C. 5 years ago, we had 6 cases of hepatitis C. Today we have over 250. We've had to work with federal, provincial, First Nation policy tables. We have our federal, provincial governments talking about what's required to deal with the opiate addiction. Again, there's the proof of concept work. We created community-based guidelines. If anybody ever wants them, we can send them to you. They may be a little outdated. We did them in about 2012, updated them 2 years ago, but they're still based on evidence and literature. And the articles I can send you as well. So our framework for how we were going to deal with our opiate addiction was really looking at 4 areas that our chiefs adopted. Treatment was the first one. Security and policing, somebody talked about you got to deal with the dealers. Reduce the demand, try and prevent the next generation from becoming addicted. And the one that's not in Canada's health policy, harm reduction's in there. They put in root causes, dealing with the historical trauma, dealing with all the root causes that creates the addiction. So our guiding principles are really looking at preventing, treating, and eliminating prescription drug abuse. We wanted to inform the government of our research practices, our policy decisions, and any kind of resources. One of the things that government hasn't really bought is our proposals around land-based healing. We were funded for Suboxone treatment programs in our communities, but they only funded 40% of what we asked for, and that 40% only paid for the daily administration of the medication. Our whole aftercare or our land-based treatment programs has not been funded. The province of Ontario now has announced some funding through the Truth and Reconciliation, where they're going to put money into land and culture-based programming. They're still very expensive to run. They're, we think, a little bit less expensive than if you sent somebody to a treatment center. But even if you were in a treatment center, you could still benefit from some of the land and culture-based programming, because it's that spiritual relationship that you gain from land activity that's so important. We had to be flexible and adaptable and culturally appropriate. I don't know what the other one said. You know, capacity building is something we've talked about for years, and somebody says, well, you know, how do we do that, and what does it really mean, and whose capacity are we building? Is it us as health professionals, or is it the community members who are going to be taking over these programs? So that's something you need to really think about, is how can you be that person to mentor someone in helping? And if that person is at the community level. I've had to do that all my life as a nurse. And you see such wonderful results from people who can actually take over your job, including the Aboriginal nurses who are actually coming out of the schools in Thunder Bay, the nursing schools. So our high school, typical brick building, sitting in the middle of a city. Grade 9 to 12, we offer the usual Ontario-based curriculum. We had the 43% of the student body addicted. Again, that was the fallout from the youth suicide crisis, the sexual predator that I told you about, but also the overwhelming burden of unresolved grief. Our students talk about losing parents, siblings, aunts, uncles, all to suicide. And do you know how we know that? Okay, so I've done about almost 500 inductions, put people on Suboxone. And we do an 8-page history. And in that 8-page history is about their trauma over the years. And every one of those talk about some kinds of loss from the suicide crisis. So we've been able to link prescription drug addiction, opiate addiction, to the suicide. We tried to tell the government that 25 years ago, and they didn't listen to us. When you think about the number of, you know, sometimes as caregivers you have frustrations, right? But you don't publicly tell people. But one of the things you do is you get into your own little circles and you say, oh, you know, this is what happened today, and you know, what can we do? And so you do that pure support. But what it does, it drives you to do things differently, and it strives you to do things better. And that's what we had to do with our high school student. So we had to we designed a program. It's all on site. Our families, our leadership, our teachers, they were all involved in what they call wraparound care. We have grief counseling, which was part of the program. Teaching kids about drugs, drug education was a big part of what we were doing. And again, language, culture, and kinship. We were teaching these students how to write in syllabics. I don't know if you know what syllabics are. The Aboriginal writing. Used to see them in prayer books all the time. And so it's the alphabet, the Aboriginal alphabet that they were learning. So our initial data from our first 51 students showed that 64% of them were women. The average age was 18, and most of them used oxycodone regularly. The majority of them, 72%, also use codeine and codeine-containing medications, and that's probably why you can buy it over the counter, Tylenol 1 over the counter, right? Canada is one of the only countries that lets you do that. And almost half of them used other opioids. There's the fentanyl, the morphine, the hydromorphone. And they were sipping on methadone, street-diverted methadone. So they were using small amounts. If you look at their average dose of oxycodone that they were using on a daily basis, they ranged anywhere from 20 to 200 milligrams per day, with an average of 76 milligrams. So that's fairly low dose. And the reason for that was, again, the cost of the diverted or the illicit black market opioids. One OxyContin 80 in our communities was selling for $1,000. So when you look at how could they afford that, they couldn't use much drugs, but the other thing they were doing is they were injecting it. The average duration of drug use was 5 years. Opioid use history was about 2.8 years. That was significant because that could tell us if you have a short duration of opioid use, your treatment can be shorter as well. Almost every student smoked tobacco, 93%, and cannabis, 94%, and consumed alcohol regularly, 88%. Again, a significant amount of them are using stimulants, mostly Ritalin, hallucinogens. You know, this just tells you that kids will use anything that they can obtain, right? It's not like they have a drug of choice today. It's going to be a barbiturate. Where do they even get that from? You know, I mean, I'm a nurse. I don't see people prescribing this. So, I mean, somehow they're getting their hands on drugs that are out there, which means they're going to get their hands on the cocaine that's laced with fentanyl. They're going to use whatever drug that they can get their hands on. So the treatment process, we did 63 students. Our duration of treatment was 30 days to 2 years. We started in February of 2011. We did 2 intakes. We actually do large intakes. We'll do 10. We did 10 each of the high school ones. In the community, we'll do 20 people at a time. We'll start on Suboxone. And so our treatment team is a physician, a nurse practitioner. I was a nurse practitioner, an RN, and then an addiction counselor. Our support is in our elders program. We have 9 elders. One of the things we teach them is how to skin beaver. We have a dog sled program. You guys would love this dog sled program because what it does, these kids are from the north where the dogs run wild, so they're afraid of dogs. So in this dog sled program, which is part of our curriculum, they have to go and choose a dog, and then they have to go and look after that dog, and they have to hitch them up, and they have to race them. It's actually a really good program that we've put into our curriculum. So it's something that you can do. I think it's under environmental studies or social sciences. The culture, the grief counseling, all our Suboxone's right on site. We lock it up there. The pharmacy delivers it. There's nothing different about this Suboxone program because we've integrated into our clinic. We have a full-service clinic at that high school. And I've been there, as I said, 14 years. I told you why already, first line. You know, Suboxone is 6 times safer than methadone. Literature tells you that. It has a ceiling effect, so once you've populated 100% of those receptors, you can't put more on board. It'll block other opiates. The other thing about the Suboxone, again, it doesn't have the side effects. If you think methadone, I don't do methadone. I've transitioned people off methadone, but the people who've transitioned off methadone no longer have teeth. They've had to get all their teeth pulled out because of dental caries. A lot of them talk about obesity, and the guys talk about no testosterone. So there's side effects to methadone, so this is safer. We have tried using generic buprenorphine to taper people off, and it doesn't work as well. If you're doing a low-dose program, brand name, we find better results. And I would talk to you about the use in maternal and child health. So this is Kaya and Marty. They have given me permission to show you who they are. They both graduated. Kaya from our high school. Marty had to leave school, and then he finished his grade 12 last May. So Marty essentially says the good thing about the program was meeting all the people who wanted to help and support you. I never got the kind of attention before as I usually tried to help other people. I would always put others before me. Also, meeting all of the other students in the program who wanted to quit was a great support. These people are all like my other family. I can't read that. Oh, we all want the same things, and hopefully all of us will be determined to stay off drugs. You know, Marty told me, we brought him to a nursing conference in Toronto last year, and one of the things he told people, he said he started drugs because his brother was murdered. Kaya, again, another family thing happened with her. Her mother was diagnosed with a very serious illness, and she became the caretaker. So these kids all have stories, right? But they all have a better future because of the treatment we provided. Okay, I'm done.
Thanks, May. You always end so suddenly that I get caught back there. Yeah, really, really fascinating to learn some of the, both the depth of the depth of despair and the tally of addictions related to trauma, and yet the success of that, of the support, the drug, and the support that goes along with it. So, great lessons for us. We have time for questions, so I'm going to open it up if anyone has questions about either part of May's talk. Go ahead.
Hi, my name is Andrea. I'm the counselor at the Teen Parent Center. We have a lot of girls that come from Whitehorse, but also from outside communities that have come into Whitehorse, maybe brought in grade 8 or 9 to go to one of the local high schools. And so we see a lot of, sometimes, re-traumatization from, for them and for their families of being sort of taken away and coming to the city. So I'm wondering, in the case of your high school, how did you deal with that piece of trauma that may be part of the addictions cycle for these students?
Okay, so unfortunately, in our high school, we've lost 7 students who have died while they were in our school. 5 of them were found in a river, and we're not sure how they got there. It says undetermined. So when you look at what can we offer families in terms of some reassurance, it's pretty difficult with that kind of track record. But they know that we did our best to try and care for them. As I told you, this is a city that's quite violent. We're known as the murder capital of Canada. So when you take that kind of environment and you try to keep young people safe, it doesn't, you have to go the extra mile. What we've been doing now is we've been setting up primary and secondary prevention programs. We've been trying to do that early identification that somebody talked about this morning, and we try to engage them very early. What I have noticed in this community, in this school, is that the last 3 or 4 years, kids are coming out with early psychosis. So you say, well, voices, a feeling of some presence. When you look at their trauma, if you look at PTSD, that all fits, right? So we're having to do more clinical, more complex clinical care. We've engaged a child psychiatrist to help us. We've engaged a PhD-prepared psychologist to work with some of the students that come out, because some of what we've noticed is some of the contagion effect, right? It's like that with suicidality, it's also like that with substances, but it's also like that with anxiety, PTSD, trauma. So what we've been doing is we've tried to be really vigilant in planning for our kids. And one of the things that has really made a difference is this year, as a result of the inquest we've had, one of the longest inquests in Ontario's history, is we put a break in between September and Christmas. So in October, they get to go home, and we call it hunting week. All these kids get to go back home. That made a difference in the burnout of, I think, our school, our teachers, but it also impacted our retention rate was improved. We had more kids staying in school for the second semester. Long answer, sorry.
Hi, it's me again. I did have a question for you that you touched on briefly in this presentation, but I was wondering if you could speak to it about both your community program and the one in the high school. You touched a little bit about polysubstance use, that the students were, didn't really have drug of choice. There was a lot of polysubstance use there, and I would imagine in your community program with adults there was polysubstance use as well. And I was wondering if you could speak a little bit more to that in terms of how polysubstance use is being addressed, or what policies that you developed around that. Like, was it sort of a no tolerance policy, or did you have a lot of room there, and how that's overall being handled with once the person has started on Suboxone, how their other poly use of other drugs might be being dealt with on a policy level and on operations level.
Okay, so when you provide treatment, like we did, what we noticed, again, there's a different substance usually that they go to. So they're not taking opiates anymore. They'll move on to things like, first of all, it was homebrew. People were taking making more homebrew. The one community I was in, all of a sudden there's more cocaine. So what does that mean? It just means the dealers are bringing in different drugs because you're treating the opiates. The cocaine was showing up in one of my communities, and people were denying that they were actually using cocaine, and what was happening, it was in their marijuana that they were smoking. So what do? What we did with them is we talked to them about it, saying, why are you using this? So some of them are in early recovery. It takes a while to let go, right? So the last time I was in one community, I said, you're still showing some cocaine in your urine. The community has asked us to test the urine. We used the little point of the little dipstick. And they said, I'm using less. And we said, okay, so when are you going to actually give it up? And they said, well, I'm getting there, right? So it's like, so treatment is really on people's terms. We don't have any rules. We don't even do a no tolerance. We have 3 rules. Don't drink alcohol. Don't sell your Suboxone. And don't buy Suboxone because it's illegal. Those are our 3 rules. Other than that, I don't think we have any other rules. Oh.
Hey, I'm just wondering what systems you guys had in place to prevent diversion of Suboxone. Like, were you allowing patients to have carries, or was it always daily witnessed ingestion?
Okay, so we've learned that there is a market, black market for Suboxone. 2 milligrams will be $20 in the community if you can get it there. So some people go to cities and they buy Suboxone and they bring it back. Now that tells you 2 things, right, as a clinical person. So either you don't have their dose right, because they're still craving. So when we talked to our CAMH addiction psychiatrist, he said, well, if they're on 6 but they're self-medicating to 8, prescribe them 8, and then do all the things that you need to do with their life to try and straighten that out, and then, taper them down again. The other thing we do is every day they get daily administration of their medication. So direct observed therapy, I heard somebody saying about dose witnessing today, is they go in to this little room, 4 or 5 people sit down at a time, they get the medication under their tongue. Before they can leave, you have to make sure it's not there. Some places are really strict. You're not allowed to wear sleeves. You're not allowed to put your hands near your mouth. You have to sit there and let it melt.
Can I ask a follow-up? Did you find that there were many patients that were requiring more than low-dose Suboxone, or still having lots of cravings at a lower dose?
Yeah, our best indicator was our adolescents, although they were using the shortest number of years, but they would say that after 9 or 10 months, they weren't craving anymore. They weren't getting triggered by watching other people do drugs or being offered drugs. So we started a 20-week wean-off program. Our final dose is 0.5 milligrams. Again, people think, okay, is that a therapeutic dose? It's both. Part of it's psychological. So we actually, when we get to 4 milligrams, we'll do 0.5 milligrams to taper people down and off. The important thing to know about tapering is that you need to use other things, right? So you can put them back under ancillary medication. So clonidine, they have trouble sleeping. We use trazodone and ibuprofen. The other thing we use is our land medicine. So we have a traditional person who actually tells them what medication or what plants to take off the land, how to prepare it, and they drink that. We also offer them 5 rescue doses of 0.5 milligrams. So if you're going to town and you know you're going to be craving or somebody's going to offer you drugs, here's your 0.5 doses. Take that instead of taking another drug. We've had some of that given back to us to say, I don't need it. We've had some people say, I need 5 more.
Yeah, hi, my name's Lee. I'm with Family and Children's Services, and I just have a question about the youth that are coming into the community to go to school. You spoke to this a little bit earlier on, but I'm wondering, so these kids have never been in a bigger community and they're more vulnerable, there's more exposure, and there's easier access to drugs. So do you have any way of monitoring that at all, or how do you protect the youth, I guess, from in their most vulnerable moments when they first come into the city and really don't have a frame of reference for anything? We do a city orientation. We have something called an amazing race.
So between our teachers and our students, we actually put them on teams and we send them throughout the city. They get to see what the city services are. They get to get on a bus. And we encourage them to use other city services. Again, as I said, our city is a little bit dangerous right now. So what we do is we really encourage sports, recreation with, we have social counselors. So we also have activities for them in the community. The dog sled program was an example of that became a part of our curriculum. But we do lots of sports. Our school used to win all the city championships in volleyball until the opiates hit. So what do we do with it? We have a chief and council in our high school. So we do have a leadership group in our high school. They work with the students. We provide 3 meals for them: breakfast, lunch, supper. Before, all our kids used to have iron deficiency anemia, our young women. I don't see that anymore. We have school program until 8 o'clock, which includes sports. And after that, they're so tired, they're going to go home to bed anyway. So keeping young people busy, keeping them engaged in cultural activity is really important. Our elders, I think, is one of the key, 9 elders is really key for us. Because they seem to be the ones that provide this, care without words that somebody mentioned this morning.
Hi, May. Dr. Sharon Lazio.
Hi, Sharon.
One thing, some of the questions around dosing and take home of Suboxone, et cetera. I think with addiction and opioid use disorder, thinking of it like how you might think of an individual with diabetes, one shoe doesn't fit for everyone. And the more practice settings and the more clinical pathways we can create to assist people with this condition and with substance use or misuse as well, the better off we are. And so for some individuals, how you manage their diabetes, they may get away with a certain level of intervention and treatment, and others need more intense. And for the opioid use disorder, we actually try to rate it mild, moderate, severe, and for how long you've used. If you've been a youth with 18 months of use versus a 65-year-old gentleman who's been on heroin for 40 years, your treatment's going to look a little different, and probably your outcome's going to look a little different. So what we might get away with Suboxone for one population, one clinical scenario, may be different for another, who we may top out on Suboxone. That sort of injection drug user for 40 years, most likely, will still be getting a lot of cravings and withdrawal symptoms and be seeking other substances not stabilized. So they may now need to go to methadone. I think we're going to hear about over the next 2 days, when we might use different kinds of pharmacology-based support, so opioid substitution therapy to treat this problem, but not forgetting about all those other wraparound services, which in the end for some are much more important to the success and recovery of their treatment. So I guess just thinking of, for some individuals, for 40 years you've been addicted to opioids, your brain's actually changed. It's really a brain condition, and you're probably going to need some kind of support lifelong. Might be the best situation. And shorter term use or not as intense, and with a lot of wraparound service, you will probably have more success with lower dose or shorter term. We really don't know how an individual will respond. And so, we kind of look at the clinical situation. So your talk was absolutely fabulous, May. Yeah. And I'd love to give you a standing ovation.
Thank you. Thank you.